Good morning. Welcome back to Open Med School. Today I'll be discussing bulbar palsy and pseudobulbar palsy. What is bulbar palsy? Bulbar palsy is element type of weakness affecting the cranial nerves arising from the bulb. Bulb is the medulla. And which are the cranial nerves arising from the medulla? They are the 9, 10 cranial accessory, that the 11th and the 12th nerve. When there is an element weakness, it is bulbar palsy. What is pseudobulbar palsy? When there is a dysfunction affecting the corticobulbar pathways supplying the bulbar muscles, that condition is called pseudobulbar palsy. Hope the distinction is clear. Let us look in little more detail into each of this. So, what is bulbar palsy? Bulbar palsy, by definition, as mentioned, is a lower motor neuron type of lesion involving cranial nerves arising in the medulla or the bulb. We already mentioned 9, 10, 11, and 12. Pseudobulbar palsy is bilateral upper motor neuron lesion of the corticobulbar pathways. The brainstem anatomy we should understand. Medulla oblongata contains the nuclei of the nerve 9, 10, 11, and 12. So here you can see the medulla. So this is a cross section of medulla. You should be familiar with. So here, this is the hypoglossal nuclei. This is the dorsal nuclei of the vagus, which is the parasympathetic. And here the nucleus ambiguous. Nucleus ambiguous is concerned with the function of most of the lower cranial nerves. So this gives fibers to the 9th nerve, gives fibers to the 10th nerve, and fibers to the cranial accessory which goes with the vagus. So nucleus ambiguous is concerned with the main function of swallowing, and also is involved for the articulation. The 12th nerve is supplying the tongue and is concerned with the movements of the tongue. So when there is a lower motor neuron type of problem, you will get weakness of these muscles, which is LM type. Hope it is clear to you. So now we look at the brainstem. So here comes this is the medulla oblongata. Is the medulla, and you can see the cranial nerves. This is the 11th nerve, this is the 10th nerve, and this is the 9th nerve. I already mentioned the main area of supply. The 9th nerve supplies mainly the stylopharyngeus, which is the motor to stylopharyngeus. Initiation of the swallowing is due to when the contraction of the stylopharyngeus occurs, when the pharynx is pulled upwards. So let us look into what are the clinical features of bulbar and pseudobulbar palsy. So clinical features depends upon the functions of the cranial nerves. As mentioned, speech is one which is affected. So because of the 10th nerve paralysis, you get a nasal tone. When the 12th nerve is affected, you can get the linguals may be affected. So overall, the speech will be nasal, weak, and slurred. Then the next important function is swallowing. During swallowing, the palate has to shut. The nasopharynx to be shut from the oropharynx. So as it is dysfunctional, what will happen? There will be nasal regurgitation and tracheal aspiration. So patient will start coughing while taking food. One important finding that occurs in the tongue on examination is fasciculations or fibrillations in the tongue. So the tongue will be wasted, the mucosa will be shriveled, especially in long-standing cases. So this is one of the very important findings that you should look for. Look at the tongue, whether the tongue is wasted, is weak, and fasciculations are present. Then the jaw jerk will be sluggish. Jaw jerk will be sluggish. The palate will be, the arching of the palate on examination will be weak, and the gag reflex will be absent. So these are the findings of a bulbar palsy. Hope it is clear. Now we look into the pseudobulbar palsy. As mentioned, what is pseudobulbar palsy? Pseudobulbar palsy is weakness of the bulbar muscles due to dysfunction of the corticospinal pathway. Not corticospinal, corticobulbar pathway. So you can see the corticobulbar fibers are coming like this. It passes through the internal capsule, goes down the brainstem, innervates bilaterally for most of the cranial mass. Suppose it is affected bilaterally. What will happen? This will produce a human type of weakness of the cranial nerves. That is the pseudobulbar palsy. That is bulbar muscle weakness due to upper motor neuron problem. So what are the features? The classical findings is a triad of findings. It produces dysarthria, dysphagia, and emotional incontinence. What is it by emotional incontinence? Emotional incontinence means the patient may start laughing, they will be unable to control it. They may start crying, unable to control it. Or there can be emotional lability from one emotion to other emotion the patient shifts. So this is the pseudobulbar. What are the causes for pseudobulbar palsy? Pseudobulbar palsy classically occurs in multi-infarct dementia. That is multiple infarcts leading on to dysfunction of the corticobulbar fibers. It can occur as a part of motor neuron disease, the pseudobulbar features. Most of the dementing illnesses, degenerative conditions lead on to pseudobulbar. So physical examination, one is the spastic speech. So suppose the patient says Trishu, they will say Trishu. That is slurring of speech, undue closeness of the syllables. The jaw jerk will be exaggerated if the lesion is above the 15 hour nuclei. And the gag reflex may be sluggish or can be preserved or well seen. So today we have discussed about the bulbar palsy, pseudobulbar palsy, the important differences and causes. Stay tuned. Thank you.